All right. So incidents and emergencies. I go a little light on this topic. There's some things like heart attack and stroke that we could cover, but you guys have all already had your CPR done, right? And that's in CPR. And we also learn about heart attacks and strokes a bunch of other classes. So I decided to shorten that up. We are going to spend some time on a couple of other things that are a little bit particular to the physical therapy world and incidents and emergencies. Now, incidents and emergencies on the licensure exam. What's the purpose of the licensure exam? To make sure make sure you are not going to hurt your patients. So the type of questions are often what not to do rather than what to actually do. All right. So incidents, emergencies, I think on this next exam, it's 12.5% of our next exam. Although it's the type of stuff that will show up on your licensure exam at a very high frequency. So important stuff. So everyone who works with patient care has a responsibility to maintain a safe environment for the patients and their families. Caregivers, again, who are caregivers? Us, yeah, any healthcare worker, anybody that provides care over a person. So it includes us. Should be qualified to provide immediate emergency care. And that's why it's required that we're all CPR and first aid certified. So how to contact emergency personnel. And in hospital and SNF settings, it's going to be important to understand what the different codes are. So if you're in a hospital for any length of time, over the loudspeakers, you'll hear code blue, third floor, code red, third floor. So if you're actually working there, you need to know what all those codes are. Oftentimes on the back of badges, it says, blue equals this, red equals that. But that is important if you're in the inpatient setting. So we should also be able to understand the important medical background of our patients, past medical histories, other diagnoses, equipments, particularly pacemakers. That's going to be something that comes up a lot. Medical alert bracelets or necklaces. I had one former student who's a PTA now, and he's a diabetic, and he never wanted to lose his medical alert bracelet, not put it on for the day. So he got on his arm tattooed diabetic right there. It's pretty cool. So really important to understand all that. Now, the past medical history, diagnoses. I have patients all the time with diabetes. Do I treat diabetes? No. No, I don't do anything about that, right? I do a lot about all of the other things that diabetes might cause, but I don't do anything about that. But is that important for me to know? Why is that important for me to know, just with your knowledge already about what diabetes is and what we do as a profession? Like what? What other conditions susceptible to what? Yep. So diabetics, if it says diabetes, the first things we know off the top of their head is they're going to be more susceptible to wounds. They're going to be more susceptible to sensation loss, neuropathy. They're also, what's their healing time? Anybody know their healing time? Slower, right? So all of that we should just know off the top of our head. What's something else that we're particularly concerned with our patients with diabetes? They have a total knee replacement. They want to get back to gardening, and they do carrying around mulch bags, like real deal gardening. Not my kind of gardening. We say, I'm going to buy and kill $50 worth of plants every single spring, and then in midsummer everything will be dead, and I'll say, why did I do that, right? So that's not my kind of real gardening, where you're saying I'm going to take care of this stuff. So they're in working out a bunch. What is our concern with diabetes? Blood sugar dropping, right? What happens when the blood sugar drops? Anybody work with a patient that's or been in the clinic when that's happened? It's happened a couple of times. Or exercise. Does she have low blood sugar? Is that what it was? Yeah. Okay. Yep. Yeah, it gets dangerous real quick. So we need to understand that patient has diabetes. We got to know it right away. PTA too, when we talk about modalities, if someone has a pacemaker, there's a good percentage of our modalities that are contraindicated now because they have that pacemaker. We need to be well aware of that and not make that mistake. So legal responsibilities, all caregivers should be informed of required legal responsibilities and limitations when providing emergency aid. The Good Samaritan laws cover us quite a bit. So it protects those who provide emergency aid to someone. So conditions that increase patient and employee risk: too few personnel to manage patients in the area. So this is actually, the employee risk is another thing that we should champion for ourselves, is there's not enough staff for the patients we've got. We cannot operate safely like this. It happens a lot more on the nursing side, and every now and again, actually at a fairly frequent rate, you'll see an attempt to pass laws on minimum nursing levels for hospitals and nursing homes. And that's important.
Hospital is like a very hospital is at a particular level for nursing. So like they're nursing the patient.
Oh yeah. Yeah. Yeah, absolutely. I mean, if you're going to be at any healthcare facility, do you want more staff or less staff? You know, so too few personnel to manage patients in the area, too few qualified personnel. Personnel is excessively busy. Personnel is inattentive to patient needs. Equipment poorly maintained. That is something we really have to champion for ourselves. That is definitely something. The Hoyer lift being broken is unacceptable. They're like, no, we can't just say, oh, just go ahead and use your backs. No, we're not going to be doing that. Personnel not adequately trained and displays careless behavior. That's a good one. Careless behavior can include not recognizing contraindications and precautions for treatment. One of the other careless behavior, we've kind of talked about this already when we talked about the importance of hand washing and PPE. One of the things was like disgruntled against your boss, like you don't like working there, so you're not going to wash your hands appropriately, you know, that kind of a thought. So that can exist here too. If a patient exhibits a negative response, unusual vital signs, maybe some dizziness, passing out, nausea, vomiting, we temporarily terminate the treatment. Physician should reevaluate the patient before any treatment is resumed, and we have to document thoroughly. Again, our first responsibility is do no harm. So if you're ever questioning that, we can put a pause on what we're doing today. That's easy to do. Because how frequently are patients coming to see us? Decent amount, right? So yeah, we'll catch you next week. It's not a big deal. Let's not make this problem worse. Patient injuries. So the number one patient injury in physical therapy is burns. And that's something we're going to talk a lot about next semester as we apply thermal modalities. But that's the number one mechanism of injury for our patients. When we take a break, remind me to look up, there was a insurance case that I wanted to bring up that goes with documentation, but also PT and PTA communication and PTA responsibility. So the patient should understand the risk. That's part of informed consent, right? We all learned what informed consent was way back in intro. We spent infinite amount of time on it, it feels like. So we'd like to apply this hot pack. Our risk of this is burn. We prevent that by adding this many layers of towels, inspecting the skin to make sure it can, removing jewelry to make sure that metal doesn't get hotter faster than the skin does. Is that okay for you to do, right? So how many of you techs actually explain to the patient that when you apply the hot pack that they have a risk of burn? 0. Danica wants to say like, yeah, I do, but yeah, let me know if it gets too hot. Yeah. You think that's good enough as far as informed consent in a burn goes? Probably not. Yep. So we'll learn more about that next semester.
Had some patients wanting to put the actual compound.
Yeah.
So
Yeah.
if they want compound, I can't do that.
No, yeah. You say go home and burn yourself. You're not gonna burn yourself here. Yeah. So next semester we're gonna pay particular attention to how to prevent burns. And again, it's the #1 injury of patients in of our patients in physical therapy. But other things that could happen: lacerations, muscle strains, ligamentous sprains, heat stress. Heat stress isn't like applying a thermal modality, it's exercising or lecturing in oppressive heat. Hematomas, fractures, respiratory distress, cardiovascular distress, all of that could happen. Again, burns are the #1 mechanism of injury for us. So prevention of employee injury is important. God, we've talked about prevention of your own injuries with biomechanics how many times a day, every single day, right? So, but also wound care, protecting yourself, PPE, hand washing, proper setup of your treatment. You guys feeling how important that proper setup and plan is now after a couple of practicals? And the better the plan is, one, the more efficient you become. And when you have 30 minutes with your patient and the next one's coming in, and actually, guess what? The next patient came in 5 minutes early, and this patient came in 5 minutes late. How much time do you have now? And guess who? Does anybody want to get shortened on their time? No. So you got to figure it out. So, but the better the plan you have, and the better your setup, the more efficient you can be with that 20 to 30 minutes. The better the plan when something does go wrong, and something could just be as simple as, I don't want to do squats today. All right, well, it's fine. I've got a good plan, and as we execute the rest of the plan, I can switch this last thing out, and you can just not lose a lot of time for that. You don't get completely derailed when you've got a good plan. And then any patient or employee injury needs to be well documented. So a procedure to respond to a patient injury: immediately provide or obtain emergency care for the patient. After the emergency is concluded, document. Document. So what was the type of emergency, and who was the care provided by? Who were the witnesses? Who was notified? Time, any special events leading up to the incident, notifying a superior and writing down everything and filing that incident report. So specific emergency conditions, I believe this is the bulk of the exam material. This specific, here's the problem. What would we then do about it? So allergic reactions. Any techs have seen allergic reactions in the clinic? Yeah. Latex. That's the most common one that we have a problem with in our clinics, because most of our clinics are clean of other things. But especially in the spring, who works in a place where we open up all the doors and big windows in the springtime when it's that first nice week, right? So, but all that pollen can definitely be part of the problem. Dust, I don't usually see a problem with dust, because every single clinic I go to is really well cleaned. And anybody ever been to a restaurant where you walk in and the fake plants in the front have a thick layer of dust on them? What do you guys think of that restaurant? No, hey, we tried the new place. I don't want to do it. Let's go back to the Muse, right? We're just gonna go. Did you work on Halloween? Yeah, how was it? Yeah. Really? You guys still ran takeout on that? Doesn't seem right for. Okay. Still. Yeah. Anyway, foods can be a problem, especially lunchtime. Eggs and shellfish are the two major ones for the most common ones. Others can happen. Usually the eggs and shellfish, if a person walks in with a severe egg allergy and someone ate eggs for lunch, that can be enough to trigger that person. The rest of them, the milk and wheat and others, they have to kind of ingest or come in contact with them, so that doesn't typically happen. But insect stings chemicals, medications, medication allergies do happen. And especially my patients get their medications changed pretty frequently, and they might not know that they have a medication allergy. And I will be the one to say, like, I think we're having a problem here. But latex is one of particular concern for us, not only with our resistance bands, but also with our gloves that we are using as well. So if the allergic reaction gets severe enough, the patient can turn into anaphylactic shock. That requires prompt medical attention. So the treatment, I've never heard of anaphylactic shock as mild or moderate. It's usually just like yes or no. But yeah. Yep. So So if you do ingest enough of it, it could turn into this. So okay, so you're the exception of I have a hard time saying like, oh, Dion had anaphylactic shock and he took Benadryl and it was fine. And like I've never thought of anaphylactic shock about that, but hey, apparently it can be mild to moderate. One, keep the patient calm. I think that's for all of our emergencies, keeping the patient calm is such an important thing. And I think that's something you get taught in a lot in your CPR and first aid class is how to keep that patient calm. How do we keep a patient calm?
Just yell at them.
Scream at them. Why did you eat those peanuts, Dion? You know better. We stay calm is the number one thing. We stay calm, speaking in good tones of voices, communicating to the patient. I'm going to elevate your legs now. It's okay. Help is on the way. Here's an ice pack, whatever it might be. So us being calm and being competent in providing assistance. If it's severe, checking the patient airway, begin CPR if needed, calm the patient, and then ingest or inject emergency medication. Do you have an EpiPen, Dion? You do? You carry it with you all the time? No problems in the restaurant with it? Oh, yeah. Okay. Yeah, no, it's a predictable anaphylaxis. So maybe that's what it's called. Yeah. So shock. The signs and symptoms of shock include pale, cool, moist skin, shallow and irregular breathing, dilated pupils, weak, rapid pulse. What's diaphoresis? Excessive sweating, dizziness and nausea, and syncope. What's syncope? Passing out. So the treatment, if our patient is going into shock, would be to try to determine the cause and remove it if possible. Monitoring their vitals, but what's important for us is place the patient supine with the legs elevated slightly. Why? Tell blood flow going back to the heart. As long as blood flows around the heart, we'll be all right. Who cares about the legs for now? It also is going to help regulate blood pressure, so the blood pressure won't drop if we do it that way. So it'll help increase that blood pressure. Add a cool compress to the patient's forehead, light blanket to prevent body heat loss, and request transportation for appropriate care. Lacerations. One, wash your hands and apply gloves. Elevate the wound above the heart if able to, and the bleeding is excessive. Why is that? Yeah, we're making it harder for blood flow to get to that area. So if it's small, clean with an antiseptic or water, place towel or sterile dressing and apply direct pressure. If it's arterial bleeding, that's that blood squirting 15 feet away from that person. You might need to obstruct the artery above the wound. Orthostatic hypotension, we've talked a couple of different times. What's some ways that we prevent? First of all, what is it? What is it? Drop of blood pressure when? Change of position, most commonly supine to stand, although it could happen as little as supine to seated. So how do we prevent that from happening? First of all, if we see it in the chart, how do we prevent it from happening? So don't move the patient quickly, right? Break up the transfer. We're gonna go from supine to long sit, wait, supine to edge of the table. Long sit to edge of the table, wait, get to the edge of the table, then try to stand, wait before we take 2 steps away, right? So really breaking up the transfer. Any other ways? We can just do exercise while the patient's supine, right? Start pumping your ankles, start doing heel slides, leg lifts, any sort of exercise to help with circulation and prevent that sudden drop. Maybe pressure garments too. But if the patient does start being dizzy, what do? Immediately lay him back down. And because the blood pressure is dropping, we would want to elevate the legs to counteract that. Fractures, have someone else do it. Yeah, it's not you. I love this part of the textbook. Like, don't attempt to set the fracture yourself. Like, great. But hey, you know what? If it's in the textbook, someone somewhere along the way said, no, don't worry. I'm a physical therapist. I could definitely do this. Nope, not us. So burns, number one mechanism of injury for our patients in the clinics. Number one, remove the agent causing the burn. That's always my first, like, if someone's having a burn, stop burning them first. Okay, good. We might need to cut away or remove clothing at the site of the burn. Removing jewelry because the patient will swell. So if we do get a burn on my forearm from that hot pack, if I'm wearing a bracelet, you'd like to remove that right away before the swelling kicks into place, because now we have more than one problem. And observe the patient for shock. Seizures, seizures are pretty interesting. I'm trying to remember. So in pathophysiology, we talk about seizures and we talk about it as seizure disorders and not epilepsy, because epilepsy has a negative stigma to it. And I didn't know that until I read that textbook. But that's something to put in the back of our minds. But seizures, classically, there's a hyperactive response in the brain, and the brain starts firing impulses too quickly, and that causes these seizures. The mechanisms for that could be flashing lights. It could be electrical currents. So some of our modalities, we apply electrical currents to it, and that could be enough to trigger a seizure. So we want to be aware of it and not use those kind of things, try to limit the exposure of those triggers, especially if they know what their triggers are. But if it does start happening, put the patient in a safe location. Do not attempt to restrict convulsions. You might have to obtain emergency assistance. I will also just make a quick note. I think classically we think of seizures as big, large convulsions. Seizures, I know a few pediatric cases where that seizure is the kid just stares into space for 10 minutes. And you can't like get their attention. They're just not there for a minute. Yeah.
We had to call and with everything. He was an older patient, but
Yep.
just steer him through the therapist. He's never done this.
Yeah, and I'm sure once they came to, they just said, "Oh no, it's just a seizure," and they think it's like, "All right, I'm just gonna go back to Walmart. I gotta go finish my show." No, we're gonna take care of this. So, so I do think probably because of TV and movies, we think of seizures as these big writhing contractions on the ground, but they could be really, really subtle, as little as eye twitch or a little as just staring off into the space. And Anyway, monitoring rate and quality of respiration. A tonic contraction might cause respiration to stop for about a minute. So that's pretty scary. But then return and be slower and deeper than normal. Don't attempt to place anything in the mouth when convulsions subside. Place the patient in side lying in case vomiting could occur. Don't attempt. Yeah, it's important to make sure. Do not attempt to put anything in their mouth. Yeah, because right, yeah, we don't worry about that. They're not going to swallow their tongue. They're not going to. In fact, they're just going to choke on the spoon or the wallet that you put in their mouth. Yeah. So, again, do no harm is the first thing. So, allow patient to rest with blanket for modesty, and that can happen, especially in the. I'm thinking of the scenarios in which we were removing patients' clothing, exposing, glutes to apply an electrical current. The electrical current stimulates this seizure, and now they are having problems. We do want to cover them always. Heat-related illness, timely for today. So this can happen quite a bit, especially in those times of years like right now when the heat is kicked on for the first time. So the fall when the heat gets kicked on for the first time, or was it last weekend when it was 80 degrees out, late fall but 80 degrees out? That can happen. The first warm time in the spring and summer where all of a sudden it's 75, and that's great, but because we're used to 55, it feels oppressively hot. Clinic opens up we're not going to turn on the air conditioner because it's still April. We'll open up all the windows, but it gets really hot. Anybody working in a PT place where that happens? So heat-related illnesses, are patients exercising in too hot of weather, happens quite a bit. So first step is we got to cool the patient somehow. So a lot of different ways we can do that. Heat exhaustion is less life-threatening, so lower the body temperature, removing or loosening clothing, placing a cooler environment, using cold, wet towels, rehydrate, rest. Heat stroke is a medical emergency, and we should seek immediate emergency care. Placing the patient in semi-reclined position, removing outer layer of clothing, quickly cooling patient with water, towels, ice. And do not give the patient anything to drink if the patient is not alert or if they are vomiting.
Do some, maybe the heat exhaustion, like cold water or anything, someone with a shot.
I'm not sure about that. I know, so the question was, if we give them cold water, will that send them into shock? I think the thought is, as we have too much heat, our blood vessels are really dilated. And then if we have really cold water, that's going to be a constricting thing. So I think that's where the concern is. But getting cooling temperature as fast as possible is what we've got to do. Yeah. Did I see another hand over here? Yeah. Heat stroke.
Maybe strictly.
Yeah, I'm not sure. I think in this notes here, if the patient's not alert, all right, well, they can't drink anything. And if they're vomiting, well, that makes sense because they're getting rid of it anyway. Yeah, well, I mean, it's one, we want to rehydrate. Two, we want to cool the body as fast as possible, and that's going to help. So I'm not sure. Anyway. A couple other things, hypoglycemia, also known as insulin reaction. You might see that in textbooks. Low blood sugar, sudden onset, patient pale, agitated, hungry, thirsty, shaking, sweating, double vision. What we'd like to do is give the patient sugar. So I've had a few patients have their blood sugars drop with our treatments. And I remember this one woman, towards the end of her rehab after a knee replacement, hardworking. She never had a problem for the 12 weeks I was with her. And then on week 13, I think she had a different time of day appointment and she skipped lunch. Like there was something that happened that helped this process. And yeah, plummeted. And I got to tell you, if you've never seen this before, it can be it can look just the patient passes out, like happened with you, Zach, right? So, this woman, it looked like she was having a stroke. She couldn't complete a sentence. She was confused. I asked, okay, let's call your daughter. Daughter lived just around the corner. She gave me 6 different phone numbers of what her daughter's phone number was. Luckily, one of them worked. And I gotta say, her daughter lived like around the corner, like 8 minutes away or less. Every single the techs that are here, do you guys know where your sugar is in the clinic? Other than your candy bars? So we always have either glucose tabs or juices on hand. And we had juice and the patient looked like she was having a stroke. And by the time her daughter was here, she drank 2 glasses of orange juice and was completely fine. Tired, but completely fine. So it can come back like that. It's really great when you see that. And then we could also have hyperglycemia, less common for us because usually with exercise, it's going to cause the blood sugars to drop. But this can happen. And you know what, with our patients, especially the more compromised patients and in the home care environments where they're not being constantly monitored, I've got plenty of patients with uncontrolled blood sugars. So we do need to be aware of it. High blood sugar could lead to diabetic coma or death, considered a medical emergency. There's a 911 call. Gradual onset, flushed, dry skin, drowsy, fatigued, confused, fruity odor to their breath. Again, that's the sugar sign. Labored breathing, vomiting, increased thirst, blurred vision. Don't give any sugar for them. And usually we need to have insulin injected very quickly. I'll say when I was teaching at New England Tech, I had a student. It was right before they're going on clinicals, and I was teaching about diabetes and what to happen. And his first week of his clinical, he had a patient's blood sugar drop, and the CI was slow to understand. I'm sure they would have at some point, but just because this guy learned it Friday and then on Tuesday, this person had. He said, "Oh, are you a diabetic?" And the person said, "Yes." And he immediately gave sugar. He looked like a hero. And he was a hero, right? He recognized what happened right away. I know the CI would have gotten around to it after just a few more minutes, but it was just so fresh on that student's mind. So pretty good. Find yourself some diabetic patients. If you see diabetic in the chart, make them do a bunch of exercises to make their blood sugar drop. And you say, "Don't worry." And you can put on your cape ahead of time. I'm the hero. Autonomic dysreflexia is a really interesting disorder. It's really narrow on who gets it, but it is a life-threatening condition. So it occurs with a patient with a relatively recent complete spinal cord injury above the level T6. What happens is there's some sort of noxious stimuli below the level of the spinal cord injury. That's going to cause a massive sympathetic nervous system response. I always forget sympathetic versus parasympathetic. What's one do the other? Sympathetic jacks everything up. Parasympathetic rests everything. So if there's a massive sympathetic response, what do you mean jacks everything up? Heart rate, respiratory rate, sweating. Yeah, anything you could think of, you say we're on hyperdrive. So this response causes an uncontrolled, widespread peripheral vasoconstriction, which skyrockets the blood pressure. So signs and symptoms, high blood pressure, bradycardia, profuse diaphoresis above the level of the spinal cord lesion. So I'll find the picture that I showed in intro. It's if my spinal cord injury is here and up is sweating excessively, here down is not. Isn't that crazy? Is that so anyway. Pounding headache, general feeling of discomfort, red blotch in the skin, piloerection, what's that? Hair sticking up. Patient might become unconscious, convulse, and respiration might become difficult. So it could be caused by a variety of noxious stimuli. The number one thing is bladder distension, having a full bladder. That's the number one mechanism. It could also be something to do with the catheter. That's the other one that usually there's a catheter line that gets caught somewhere and tugs, and that's the noxious stimuli to cause that. Could be fecal impaction, pressure ulcers, tight straps from orthotics, or the urine collection bag if they're attached to the patient. Local pressure, could be exercise, could be anything else. So the first thing that we want to do is the patient in a semi-recumbent position, not in supine, and definitely not with legs elevated. Why is that? If they're going to be in supine, or especially if we place them in position of shock, which is leg elevated, what's that going to do for them? It's going to increase their blood pressure even more. The biggest problem with this is the blood pressure response. So we do not want to do that. So we want to get them in recumbent position. Why not sitting all the way straight up? Just because they're going to fall. The likelihood of falling there. And depending on the level of injury, they might not have trunk control anyway. So that's the reclined position. Remove noxious stimuli if able to identify. Usually you'll be able to look and say like, oh my God, the catheter, like, and then monitor the patients, and then we need to call 911 to administer hypertensive medications. I haven't had any patients with that, but guess who did? Pat McCormick had a patient with spinal cord injury, and luckily he was working at Newport Hospital outpatients, so he was able to just press the button on the wall and wheel them right into the ER. That was pretty good. But yeah, Pat McCormick, and because who would it happen to other than Pat McCormick? So other concerns we could have: strokes and cardiac arrest. What's cardiac arrest mean? What's heart attack? Yep. So you've already known about that. If that shows up on an exam, I don't think it's any knowledge that you don't already have for that. So that's what I got for incidents and emergencies. Any questions? All right. Why don't we get some cold cloths for ourselves, and then we'll come back and start doing edema stuff, okay?